Vice-Chancellor, ladies and gentlemen, friends, colleagues, delighted to see so many of you here. Better late than never, I guess, although I did have an inaugural lecture at UCL when I was there. So, for services to Psycho Oncology, Psycho what? Here I am, 1st of March this year at Buckingham Palace with the Queen. Great that I've had another opportunity to wear the same outfit. So what a laugh, eh? The Queen and Buckingham Palace. So how did I get here and what did she say? Everybody wants to know what the Queen says to you, and I don't think you're really meant to admit what she said, but I'm going to break with tradition, as I always have done, and I'm going to tell you. You can see my children and Val Jenkins in the front row, not knowing whether to laugh or cry, but the Lord Chancellor said, "The most excellent order of the British Empire to be made a Dame Commander, Professor Dame Lesley Fallowfield, for services to Psycho Oncology." So I trotted up, Queen. Congratulations, what you do sounds a bit sinister. Sinister, Your Majesty? Do I mean sinister? Well, yes, I suppose I do. What exactly is the psycho part of oncology? She obviously watches the wrong sort of movies. Anyway, what is psycho-oncology? Essentially, it's research that combines behavioural, psychological, social, and the emotional with the physical aspects of cancer. We work on how all this impacts on patients, of course, but also their families and the healthcare professionals that are looking after them. It includes all stages from cancer prevention through to end of life. It might comprise measuring patients' quality of life, developing interventions to help adjustment and coping with not just the diagnosis of having a life-threatening disease, but also the side effects of treatment. So how on earth did I get here? Well, I had a precocious interest in science since babyhood. I don't know if you can actually see the title of the book there. It actually says, How Nature Helps You. I thought I had a pointer with me, but I don't think I can find it. The fact that it's upside down demonstrates also that I always wanted to look at things from all angles. Good training for a scientist. What was happening in the early 1950s? Well, the Queen was crowned. Cancer in the early 50s was really in its infancy in terms of research. Crick and Watson had actually described the structure of DNA in nature. I love the fact that they said this structure has novel features which are of considerable biological interest. At the Institute of Cancer Research and the Marsden Hospital, scientists were producing derivatives of mustard gas that actually had some anti-cancer properties, and they'd just started developing new chemotherapy drugs that would actually inhibit that DNA and RNA synthesis that's needed for cells, particularly cancer cells, to survive. So let's move on to the 1960s, where I show up at Parkstone Girls' Grammar School pool in Dorset. Here's me with my dog and my very horrible school uniform. And when we arrived, the English teacher made us all write an essay entitled All About Me. Now, when my mother died, I found that she had actually kept all my old reports, all my old textbooks, all my old and I found this, and I'm just going to show you a little snippet from All About Me. I'm 11 years old, have curly light brown hair. My hobbies are stamp collecting, photography and reading. I sound really nerdy, don't I? When I leave school, I wish to be a veterinary, spelt like that, surgeon, but if I fail the necessary, spelt incorrectly, qualifications, I'll be a kennel maid. The English teacher was not awfully impressed. B-. If you are to aspire to your worthier ambition, you will need to work on this appalling spelling. Okay, well, my spelling did get better, but I didn't get the necessary qualifications. And so I showed up at Guy's Hospital in 1968. The motto of Guy's Hospital is Dari quam accipere, which means give rather than receive. I think I gave it my all. They didn't give me much money though. £13, 14 shillings and 11 pence was my first full month's pay. Anyway, I adored nursing, absolutely loved it. I was fascinated in it, I loved the people. I did not love, however, the ward sisters or the hierarchical structure. Here is a snippet from my, the most horrible ward I ever worked on, Sister Smith. Although competent, you are far too noisy, rather too sure of yourself, utterly disrespectful to more senior nurses. You spend too much time talking to medical students and doctors, even consultants, and seem keen to get one up on them. What she failed to understand was that I was fascinated by medicine and why things worked. Why did we have to do certain things? What was the basis of all this? I loved going on the ward rounds, listening to the consultants talking about the differential diagnoses, and I did lots of reading, and sometimes I probably did think, well, I know a bit more than those stupid medical students about this. Anyway, that was my report. I was quite upset, and she said, but didn't write down, for some reason the patients seem to love you. When I said she could have at least written that down, she said that was another demonstration of my insolence. Okay, so what was the treatment of breast cancer when I was at Guy's in 1968? The importance of hormones was actually being examined. I worked on a ward called Martha, and Professor Sir Hedley Atkins was doing a lot of work on the hormones that might affect breast cancer. Treatment was barbaric. Patients with advanced breast cancers had their ovaries removed, others had their adrenal glands removed, and some were sent to the Maudsley Hospital where a neurosurgeon would perform an operation to remove the pituitary gland. As far as the breast cancer surgery was concerned, this ranged from radical mastectomy, removal of the whole breast, to lumpectomy, wide local excisions and removal of the lump. All of this, however, based on surgeon belief or preference, very little to do with what a patient preferred. There were no multidisciplinary teams to discuss treatment or specialist breast care nurses to help patients. And furthermore, there was little consent for experimental treatments. So let's move to the 1970s. I did complete my nursing, loved it. I moved to Brighton and I got married. I worked briefly at the county and then as a practice nurse for a group of GPs in Hove. And I had 2 children. Great. But what was happening to my brain meanwhile? Yeah, that was all fine. Anyone know who these 2 people are? Harold Wilson. Who's the other lady? Jenny Lee. She was the education secretary, wife of Anurin Bevan. And Jenny Lee and Harold Wilson had a dream of something called the University of the Air, which later became the Open University, to try and actually help people who perhaps, for one reason or another, hadn't gone through the traditional route, actually achieve a university education. I embraced this with gusto, and I did all sorts of courses in all sorts of things that I didn't know anything about and loved it. But then I did a course in psychology, And I read this book called The Science of Mental Life by a guy called George Miller, who was actually one of the founders of cognitive psychology. He'll become relevant later on. But here comes the educating Rita moment. All seen the film and the play? Well, one of my tutors, because I started doing lots more psychology courses, one of my tutors at the time was a guy called David Hiles, and he was a tutor here at Sussex. And he said, "What are you messing about at? You should be doing this. Come to Sussex, they'll exempt you from half the course, I'm quite sure. You should be doing it." So in 1979, I came to the then department, sadly no longer, Department of Experimental Psychology in the School of Biological Sciences. The motto of Sussex was "Be still and know." I'm sure Sister Smith would be very happy to know that I actually ended up somewhere like that. Now, as part of our undergraduate course, we had to do an undergraduate project. Here are my children, Carrie and Jonathan, and some of you might be able to see that Jonathan, age 5, has developed a squint in his left eye. All of a sudden, he developed it. And I thought, oh my God, he's got a brain tumour or something. No, he'd just inherited my rubbish eyesight, and he'd got cortical suppression of one eye, and it had just started squinting. I took him to the Sussex Eye Hospital, where they had a new expensive instrument called the CAM vision stimulator, where children basically sat in front of this machine with their good eye occluded whilst these different spatial frequency gratings went round and round. As ever, I was quite interested as to how and why this worked. And nobody could really tell me. So I went up to Cambridge, found the inventor, Professor Campbell, who was an FRS, and he told me all the theory behind why it should work. But I said, has anybody done a study to see why it works? No. So thank you, people at the Sussex Eye Hospital. They let me do a project there. And I got my undergraduate project published, which was a bit unusual at the time. Essentially, we showed that it didn't work. All you needed was to really supervise children doing intensive things. You didn't need this fancy machine. As a result of that and my degree, I won an MRC fellowship, and also I got a fellowship in Cambridge part of the time because I needed some fancy equipment. What I was interested in was a problem that affected people whose optic nerves started to degenerate from various problems, in particular multiple sclerosis. Now, one of the interesting things about multiple sclerosis was that people would often present with something called optic neuritis. And this would mean that all of a sudden their vision would go very, very cloudily. Maybe a few weeks later, vision would return, but it was never quite the same as in their good eye. If you actually gave these patients conventional clinical tests like a Snellen eye chart, dark letters on a white background, or an Ishihara colour plate, they'd appear entirely normal. So I actually developed some ways to measure the integrity of the optic nerve that conventional clinical tests just could not actually determine. Several publications from it. Here's me, look at the hair and the glasses, wow. You can actually see the West Pier in the background there. It was still up then. It shows how long ago it was. My DPhil was the perceptual correlates of optic nerve damage, and the great excitement for me when I was at the Brighton Centre getting my doctorate was that that man, George Miller, whose book I'd picked up when I was doing the Open University, was getting an honorary degree. So that felt really, really nice. Okay, so I was really sort of excited by this research world. I got offered a job in San Diego, and I was tempted to go over there, but something happened during my degree. If you're in effect, I swapped my DPhil, my MRS, my missus, for a DPhil. Husband departed during my doctorate, and I needed a lot of help from friends, family and friends, to look after my kids. Liz had children the same age as me. She used to pick my kids up from school sometimes. She'd do some of my experiments. And she developed acute myeloid leukemia and had one of the first bone marrow transplants at the Royal Marsden Hospital. She got something called graft versus host disease and died very miserably from that. One of the last meetings I had with her before she died, she said, "You're meant to be so clever. Why don't you do something important? Like why doctors do things like this to you and don't tell you what might happen, give you options." So I thought about that long and hard, cried a lot about it, and I read an article by a charismatic surgeon called Michael Baum saying that he thought the psychological aspects of breast cancer were poorly understood. Mike is an amazing man. He was always interested in humanising surgical treatments for breast cancer. He did lots of research trials looking at hormone rather than chemotherapy. He used to be a firm supporter of breast cancer screening. Indeed, we did one of the first studies at a screening centre in Butterfly Walk in Camberwell Green. He's become disenchanted with that recently, or the last few years, but he was always looking to challenge orthodoxy, do different things. He also was interested in psychosocial aspects of care, measuring quality of life and communication skills. I made an appointment with his secretary to see him, and when I arrived there, he said, "Well, what are you doing? Are you a patient? I mean, you know." So I said, "No, I want to do research in cancer." And he said, "What exactly?" And I said, "Well, I don't know yet, really, but here's my CV." And he said, "Well, this is all very impressive, but nothing to do with cancer." I said, "Yes, but my best friend has just died of cancer, and I want to work in it." And he said, "Well, you know, go and see a counsellor or something, but I'll hang on to your CV." And as I was leaving, I turned round, and he was already doing something else. And I said, "Look, I know you think I've wasted your time, but I am absolutely determined that I will work in this field and make a difference, and I will find someone in the world who'll give me a job. I can measure difficult things. I can measure things that people think you can't measure. That's what my thesis was all about." So he phoned me up and gave me a job. And Sheila Madden, as was working with me at one stage there. Hi. Breast cancer in 1984. Most surgery was performed by general surgeons rather than specialist surgeons. The majority of patients had a mastectomy, that's removal of the breast. Relax, there aren't lots of gory photos, I promised. Lumpectomy, where you removed just a segment of the breast or just the lump, was still a bit rare. Psycho Oncology, quality of life, was rarely mentioned. There were few standardized, well-validated measures of quality of life. In fact, if you Google Scholar 1984 cancer and quality of life, you'll find 8 papers, and 2 of those were written by Mike Baum, actually. The sad thing is that we knew that between 20 to 30%, depending on what measurement you used, of women who had their breast cancer treated suffered anxiety or depression or both post-surgery. They also, many of them, had a loss of libido. Because the breast is such a powerful symbol of motherhood and femininity and sex as well, everybody thought that these problems were due to loss of the breast. And Mike wanted to do a randomized clinical trial, seeing how women who were in this study who had either a mastectomy or breast conservation actually fared. We published the paper, which Malcolm has kindly already talked about. The trial was a failure because we couldn't recruit enough patients to get statistical significance, but I had enough access to patients to look at psychological morbidity. This was one of the first randomized trials that was ever done, and it showed that anxiety and depression and loss of libido was equally high, therefore wasn't due to breast loss alone. Over half of the patients in that study felt that information that they'd been given prior to surgery, prior to joining the trial, had been inadequate. And it really fueled in me a desire to improve ways to measure quality of life outcomes, examine interventions to help people cope with symptoms and side effects, and improve this information provision. So I did lots of other studies in breast cancer. If you're interested, you can look them up. I stayed at King's with Mike on annual renewable research contracts, needed a job, so I went to the Royal London Hospital where they were changing their curriculum to join with Bart's Hospital. So I had a senior lectureship there and I was running the research. Then I went to University College, to the Department of Oncology, and the Cancer Research Campaign, as then was, gave me the money to develop my own research group, so I didn't have to keep teaching undergraduates, I could focus on research. Alistair Smith, who was then the Vice-Chancellor of Sussex, phoned me up and he said, Lesley, this is the annual Can We Persuade You to Come Back to Sussex call, but before you say no, we want to be a medical school with Brighton, and if we've got some groups in medical research already here, it might enhance the bid. So we came, or some of us came. So who are Shawsey? The team oscillates wildly depending on basically how much money we've got, because we're 100% research grant income funded. At one stage in London, I had 34 researchers, but here is the small is beautiful, the small current team. And some of them are in the audience, and I'll name check them later when we're talking about some of the studies. So what do we do? Well, essentially we're like gall, split into three parts. There are three main areas in our research portfolio: national and big international clinical cancer treatment trials, basic psychosocial research, and development and evaluation of interventions to try and help people, and education and communication skills training. So let me show you how this works. When you've got a new treatment, it could be a new procedure, it could be a new drug, it could be a new way of giving the drug, you always have to measure the benefits and the harms. You know, sort of, yeah, you might get an improvement in 6 weeks extension of life, but what are the side effects? How long do patients have to stay in hospital? We also have to work out, have we got instruments that can measure all of these harms that might be relevant? Then, can we fix them if we actually see that there are harms? Because it could be that you've got a really, really good drug, but it's got lots of side effects, and if only you can put something up front to help patients with those side effects, it would be really valuable to have it. And then, what are the information and communication needs? So you can see how those three themes that we work on all feed into each other. So let's look at just some of the clinical trials. All advances in cancer treatment are demonstrated via clinical trials, and you usually need to have lots of patients in those. The focus, the primary outcome that most people are looking at is how long people survive. Does the new treatment produce benefits in terms of survival or controlling the cancer compared to the old one? But not all patients just want to increase the length of life. And many of them want to actually know that the quality of their life will improve. So we have to be able to measure those things. So SureC coordinates the psychosocial quality of life protocols of lots of national and international trials using various instruments. I've just got some of them up here. I mean, some of these are very big studies with thousands of patients in from different parts of the world. Now let's look at this measuring patients' quality of life. Virtually every new drug appears initially to have fewer side effects than the standard treatment. That's because it hasn't been used for long enough very often. But there's also another slight problem, which is a reliance on the clinicians reporting the frequency and the severity of the side effects when patients come into clinic. Now I'm going to show you some data. This is from more than 1,000 patients with breast and lung cancer who were in 3 different trials receiving different types of chemotherapy. The doctors had graded the toxicity for these quite common side effects as 0. But look at the percentages who had had hair loss, diarrhea, constipation, vomiting, nausea, anorexia. You'd think that you were looking at 2 different populations. So many side effects go not just under-recognised and under-reported, but also, therefore, under-treated. So why are there these differences? Are doctors absolutely hopeless? No, I love doctors. I've tried very hard to stay married to at least 2 of them, demonstrating huge commitment to the cause. When you listen, as we do, we videotape and record doctors talking with patients, one of the things you see is leading and multiple questions. Clinics are busy, so people need to get through things quickly. And we've got one of the most famous oncologists in the country, who I will not name, saying to a poor patient with lung cancer, "You're not having any more diarrhea and vomiting since we gave you those pills, so your appetite's improved and your weight's gone up, hasn't it?" Okay. There's also a phenomenon that we see called ascertainment bias, which means that you tend to focus on the things you expect to see. So you ask people about those things, and therefore all these unexpected new things aren't there. Patients also are sometimes reluctant to admit to the presence and severity of the symptoms because they sometimes are scared that the treatment might be stopped if they admit to them. They could be embarrassed about some of the side effects, and a lot of people just don't want to appear ungrateful or complaining. This wonderful doctor is saving my life. I'm not going to tell them that, I'm shaking with fear about recurrence, that I'm being sick and doing all these things. So as we can't rely, for all sorts of reasons, on just what doctors record in the notes, how can we measure these things using patient-reported outcome measures? Lots of different ways of doing it, sometimes semi-structured interview schedules, but more commonly self-report questionnaires. And you might think it's really simple to just write down a load of questions on a questionnaire and give it to people. It's a real art to ask the questions in the correct way. Psychometrics is quite a difficult sort of science in itself. And we have actually contributed to the development of lots of measures, as Malcolm kindly mentioned in the beginning. And isn't it great? Fallowfield sexual activity, Fallowfield SAC. What a great instrument. All of these also have to be translated into many languages and translated and field tested because we're doing studies in lots of different parts of the world. So what about our second theme, basic research and ameliorative interventions? What are the problems experienced by patients with cancer? They are myriad. They have lots of problems, even though we've got so many great treatments now. Compared to when I was at Guy's, working on breast cancer wards and other wards, we've now got a whole raft of really, really great treatments. They have actually converted many previously absolutely lethal cancers into chronic long-term conditions. Testicular cancer, some of the skin cancers, some of the childhood leukemias that automatically used to mean sort of certain death now can actually be treated very realistically and well. But we have to think about the side effects and what we can actually do to help people with them. So I'm going to go through an example of a newish procedure called sentinel node biopsy. Now, most women who have breast surgery will have some investigations done under their armpit. Basically because you've got lymph nodes there that if they have actually got cancer in, will help direct the type of treatment that the woman might go on to need. The problem with axillary surgery, even in very experienced surgeons' hands, is that it can cause terrible lymphedema, those dreadful big arm swellings, pain, numbness, and a loss of mobility. So there was a new technique which meant that if you actually injected a radioactive substance during the operation into the axilla, you could actually see whether or not there was a sentinel node that would tell you whether this woman needed to have either or her lymph nodes removed or sampled, or if in fact you didn't need to touch the axilla. So could this new technique spare some women with clinically node negative breast cancer the surgery? And there was a trial called Almanac to actually compare people who had conventional armpit surgery with this new technique. So what are the benefits and harms potentially of this? Well, the putative benefits were, of course, that you could spare patients axillary surgery, and therefore they'd have less arm morbidity without actually compromising the fact that you needed information about nodal status to direct further treatment. Patient self-report of quality of life and arm movements was a really important outcome. So can we measure these benefits and harms? Well, you could certainly see whether you could detect the nodes and whether or not this influenced somebody's likelihood of recurrence. But could you actually measure the patient-reported bit? There was an instrument called the Functional Assessment of Cancer Therapy breast version that looked at overall quality of life, but it wasn't really going to tap into the arm movements. So we had to develop, validate a subscale that could be included with this. So bear with me. The results showed that sentinel node biopsy was possible, and it also reduced arm morbidity. We actually found, if you look at this slide, the blue are people who had to have armpit surgery. The pink columns are those who had sentinel node biopsy. And if you look at baseline through to 18 months, you can see that numbness was a big problem for those having standard treatment, but not for those having sentinel node biopsy. One or both arms are swollen or tender. Again, there's a big advantage to those who actually have the sentinel node biopsy. The pink people are faring much better. And then with overall quality of life, in this case, high means good. And if you see here at baseline, everybody's got quite a good quality of life. Those who have it sinks, and it never gets as good as it was to start with. But those who had the sentinel node biopsy are fine. So that was a really important finding. But what about patients who have to have armpit surgery? Can we fix or prevent the harms? And I'm delighted to see Di and Lynn in the audience, two physios in Brighton who helped us. Val Jenkins and others designed a yoga program, and you can see here people from the Brighton Breast Cancer Support Group all being filmed doing the exercises. So patients actually went through the exercises. Lynn and Diane went and measured their arm movements using all conventional tests, and the data showed when it was published last year that people would do the exercises, and those that did got benefits from it. More recently, my colleague Helena has got an app, Be Well, and you can see Alison from Python Golf Club, thank you, was filmed doing all the exercises, and basically people can record their progress and how they're feeling as they're doing them. It's very important to have things that you can launch on different platforms these days rather than just pencil and paper reporting on questionnaires. And we've got a great web manager, data manager, Shirley, in our group, who's been transforming the way we can actually give all these sorts of measures to patients. Now, I focused very much on breast cancer because I thought that's what Malcolm wanted me to do, and that's where I really came in. But we are doing lots of other things, and one of the pieces of work that has caused me the most angst, in fact everyone in the group angst, and yet I'm also enormously proud of, is something called the UK Collaborative Trial of Ovarian Cancer Screening. Ovarian cancer has got, sadly, still quite a poor prognosis. Only 40% of patients survive 5 years. And so it's a big question as to whether or not screening would permit earlier detection and therefore earlier treatment that might offer cure. This is the biggest ovarian cancer screening trial ever done anywhere in the world. 200,000 women who have been randomized to either just control, that means people just watch and see if they get ovarian cancer and symptoms, or whether they have two different types of screening approaches. A blood test, which if it is high, is repeated, and if it's still high, they have to have ultrasound or ultrasound screening alone. We're looking, Shorty, at what are the harms and benefits of this and which screening method is the best and most acceptable. We've been coordinating this study. We've got 157,000 women in it, and you can see that absolutely everybody in the unit has at some stage had to help with the filing. The amount of data we've got is huge. We've had volunteers doing it as well as us. Everybody's had to do it. But last year, towards the end of last year, in the Lancet, we had some early results showing that you could indeed detect ovarian cancer at a slightly earlier stage, particularly if you use the multimodal screening. And the Department of Health and NICE and other people are looking at this. We need another year before it's all finished, and then they'll decide whether or not to launch ovarian cancer screening like breast screening and cervical screening. Now I want to move on and talk a bit about decision making. I've already alluded to the fact that, not everybody wants to live as long as possible at any cost. So is lengthier survival worth the treatment side effects? And indeed, how much survival benefit is required to trade off any disadvantages and side effects? There are studies that will suggest that patients will take anything you throw at them with very high toxicity for very small benefits, but most of that work is flawed. And if no clear survival benefits exist between treatments, let's say that you've got 2 treatments, both of them will mean that you survive the same length of time. It's absolutely crucial that we actually have more information about the impact on quality of life, because that could really influence what a patient chooses to have. Now, not all drugs offer cure and lengthy survival. And many of the newer drugs that you hear about, the Daily Mail is always sort of going on, isn't it, about some new drug that's brilliant, that isn't it a disgrace we can't have. But many of these newer drugs are approved on the basis of something called progression-free survival. Now, this is quite a difficult concept to understand. Essentially, what it means is that there was evidence during the trial from scans that the cancer didn't grow whilst patients were on the drug. It was controlling the cancer, but it doesn't automatically mean that you will live any longer. Now, it could be that progression-free survival is great, because if you, for example, have got lung cancer and you've got a treatment that stops the cancer growing, perhaps you're not so breathless, perhaps you can do more activities of daily living. But it's very important that patients understand that that's what the therapeutic aim is. It's not going to make you live longer, but it might help you feel a bit better. So we need to actually measure goals and priorities and trade-offs, and what sorts of things happen to quality of life whilst people are on these things. I'm delighted that lots of people are here tonight. Richard Simcock, hello, Fiona, other people from the Sussex County. They contributed to this study that we've just published, showing that the therapeutic aims of drugs that offer only progression-free survival are not only misunderstood by patients, but that sadly and strangely, the oncologists that are dishing out these drugs might be very optimistic themselves about the likely benefits. We actually followed patients who were starting on these new drugs, and we asked the doctors to tell us what they thought the benefits to the patient would be with or without treatment, and how long they thought they'd survive. And then we were following the patients through, hopefully until they're 6 months, or until they actually came off the drug because of unacceptable toxicity or because the disease had indeed progressed. The expected benefits that some of the doctors expected to see exceeded the results that we'd found in clinical trials. Sadly, some of our patients died or were in a hospice before we could even interview them. And more than half of our patients said that palliative care options instead of the new treatment hadn't been discussed. Now, there's lots of problems about this, because we know that early referral to palliative care, palliative and supportive care, can not only extend survival but improve quality of life for the patients and their families. And yet, some people feel rather nihilistic about the benefits of quality of life. It's not real of hospice care or palliative care. It's not real treatment, like hitting it hard with a new drug. And there's a sort of, I can only describe, folie à deux that exists between the patient and the doctor, who want to hope against hope that this drug might actually do the trick. Sometimes it will, but not always. Now, remember, I love doctors. Remember that, I'm not a doctor basher. Well, now and again, maybe, depends who they are. Let's look at this thing about prognostication. Doctors often say to me, well, cancer's a very sort of unpredictable sort of disease. It's very difficult to tell how long somebody would live. Well, if that were true, you'd expect to see a Gaussian curve. In other words, that if you ask doctors to predict how long somebody's going to live, some will be a few will be hopelessly over-optimistic, a few will be hopelessly pessimistic, but the vast majority will be somewhere in the middle. But every study that's ever been done has shown that accuracy is very poor. The direction of error is always heavily skewed into the overly optimistic direction. And there's a rather alarming sort of piece of work that shows that the better a doctor knows a patient in terms of the length they've known them, in terms of the intensity of the contact they've had with them, the more likely they are to overestimate survival. You love some of your patients, so you want them to be the one that just actually does benefit a bit more. So patients become twice removed from prognosis because foreseeing, that's the estimate about survival, is likely to be optimistic, and then the foretelling, the discussing it with the patient, is subject to conscious and unconscious ambiguities or deliberate evasion. Now, we did a survey of young oncologists throughout Europe, and two of the statements on this survey was, I find it hard to be truthful about prognosis with patients I like, or if I am too empathic, I cannot make objective decisions. The rather alarming finding was that nearly 2/3 of men said they couldn't be truthful with patients that they liked, and they couldn't be objective when they were empathic with people, and more than half of the women were. We published this in Lancet Oncology. It made the Daily Mail, the Times, with chummy doctors are bad for your health. And we run the news quiz. I couldn't believe it. Sandy Togsvig saying, why would chummy doctors not be very good for your health? But it is a quite alarming sort of finding, and it's because doctors are nice. It's because they're lovely people. They want to cure people. They want them to do well. So we need to come on to the final bit, which is communication skills training. There's evidence worldwide, not just in the UK, that the communication skills of most healthcare professionals, nurses as well as doctors, are often quite poor. Now, why is this? It's a core clinical skill. In the course of a hospital career spanning around 40 years, a doctor is likely to have between 120 and 200,000 interviews with patients and their families. That is a heck of a lot of times to do anything. That's more times than they'll have hot dinners, more time than they'll brush their teeth, certainly more times than they'll ever floss them. It's more times than they'll ever have sex, even if they're true enthusiasts. And yet it's the one thing that in most medical schools, even some of the newer ones, if you contrast the amount of time devoted to procedures that they'll barely ever use with the amount of time given over to this core clinical skill, you can see why there's a problem. So we were given quite a lot of money by Cancer Research UK to develop and then evaluate some 3-day communication skills training programs. This study involved 168 doctors throughout the country and more than 5,000 patients. We went into clinics, we filmed them with their patients. We took some doctors away for 3 days with actors, big simulated patients, did lots and lots of things, or we gave people just written feedback, or we just left them alone. Then we went back into their clinics 3 months later, and then 15 months later, and we showed that we could certainly improve the skills of doctors, and that moreover, these improvements were enduring. They lasted, they didn't just sort of evaporate. The problem was, though, that these courses were not only intensive, they required a lot of money to support. So we went into, there you are, Richard, without a beard. Much better. Actually, I'm a frustrated movie director, really. There's Roland Brinton pretends to actually direct our movies, but we love doing this. I like makeup as well, so ever the drama queen. Could we actually design a DVD-based program that could equally sort of change and improve skills? Could they be effective? So we designed some DVDs to talk about randomized clinical trials, communication about early experimental treatments, which is really quite tricky to do, and do they work? Essentially what we did was we videotaped our participants before and after the course, discussing trials that they were familiar with. These tape recordings were then evaluated by a coder. The participants rated their own self-confidence. The simulated patients or actors also rated the participants, and we found significant improvements. I don't know how well you can read these, but basically that line there, okay, anything over there means you've got a big improvement. That's all you need to know. Isn't it lovely to have a statistical slide where it's so simple to see huge benefit to actually having the course? People could not only talk to patients about different types of trial, but they could also deal with different types of patient. The internet guru who's read all the literature and knows what he or she wants, the suspicious patient, the deferential one, or patients with a preferred treatment arm. Because we not only showed that we could do it and it worked, it led to a major rollout of the programme. Wales, in particular, are still running all the original courses. Canada took them, the Scandinavians, Australia, and Germany. We do lots of other programmes as well. I've already mentioned the fact that we can't afford all the new drugs that are coming on the market. We just can't. When you've got a finite amount of money in the health budget and infinite demands, someone has to do that King Solomon cutting the baby in half or deciding who's going to have treatment. So we did some research looking at the views of patients, the general public, about access to these. We also did some surveys with doctors, and the Department of Health commissioned us then to do a whole series of training DVDs on how to talk about unavailable, non-NICE approved drugs, called Getting the Right Balance. This is why we're different from other groups. I mean, sometimes people think they can do good things. It's a bit like, sort of motherhood and apple pie. You've got to have done the research first to show where the problems are. Then you design something that you think might help with the problems, and then you actually test whether or not they do lead to any improvements. I wrote a report for something called the National Patient Safety Agency, who were worried about litigation and medical error. And after that report, they again commissioned us to do some work on talking to patients about medical error. And Malcolm's already mentioned that actually the delivery of cancer care now is not really just one doctor or one nurse talking to a patient. It's a serious team business, and we run courses for multidisciplinary teams. Now, what about the patients? Let's get back to the patients, and I've almost finished, if you're dying for a drink. Patients, of course, do need more information about the treatments, the management policies that people are offering them. Cancer has become incredibly complex. Used to be quite simple, but because of all the huge advances in molecular biology, the understanding that we now have about the different types of cancer, you almost need an undergraduate degree to understand the logic, the rationale as to why somebody might be recommending something over another, or suggesting you go into a clinical trial. So another part of our work is to make balanced, user-friendly, evidence-based materials, DVDs, leaflets and booklets that describe either trials or a treatment policy. So all the treatment options are described, outcomes with and without treatment, the uncertainties that are there about the clinical trial. And they contain, thank you Pycombe Golf Club for joining in here, They contain examples of healthcare professionals talking to patients, lots of very user-friendly and easy graphics, and patients or people who could possibly be patients asking typical questions. So what are we currently doing? We do, for a tiny group, we do a massive amount of work. Val Schilling at the moment with Rachel Starkings is leading on a project called PROACT, looking at the impact of cancer on their informal caregivers, and some very interesting work coming out of that. Val Jenkins is doing a study called ExtraQual, experiences of having different treatments. We're measuring quality of life in lots of cancer treatment trials, as we always do. And we've just started some new training programs talking with patients about metastatic bone disease, about risk and treatment in the context of genomic testing, and finally some exciting work that we're starting with Melanie Flint and her colleagues from Brighton University, looking at the neuroimmunological, that's difficult to say at this time of night, and biological factors that underpin personalised supportive care programmes for patients. It's dangerous to put up an acknowledgement slide because I'm bound to have left off lots of really important people. I mentioned Val Jenkins, who, as Tracy Woodcock, my PA, mentioned, had been working for me for 20 years. And Tracy said, "Good God, Lesley, that's longer than some people get for murder." But the people I really need to thank are the absolutely amazing, the thousands of amazing patients, their families, and the general public who've always helped us, embraced our research so fulsomely, because a lot of these patients are now dead, but they gave up so much time and help so that others coming after them might benefit. So, the embryonic scientist became the aspiring vet who couldn't spell, who became the noisy, jumped-up nurse, who became the hippie psychologist. It's funny, I remember, actually, Pete Clifton's here in the audience. I remember we used to go and sit in what used to be called the Gardner Centre, the Attenborough Centre now, having a pint of beer, convinced neither of us would ever find real jobs. Became the psychophysicist and neuroscientist with bad choice of hair and glasses, became the psycho oncologist, and then a dame commander of an empire that doesn't exist. I'm quite sure that sadly in my lifetime cancer will still exist, but I hope that the work of all the psycho-oncologists, there aren't many of us, but all the psycho-oncologists in the world will actually help the patients who are suffering from cancer just a little bit better because of the work that we've been doing. Thank you ever so much for your attention.